He's 77, and I'm 79. I told them the next time I got it, and they didn't come to my room.
All right, it's 9:30, so I'll go ahead and get started. Oh, it's not on. I'll be bringing the baby later. Can everyone hear me okay? No? Okay. All right. So good morning. I'm so excited to talk with you all about all things genetics and cTTP. I'm Hannah Helber, and I'm a genetic counselor at Texas Children's Hospital. You guys can ask questions as I talk. I've got slides, but if you guys want to ask questions this whole time, that's totally fine too. It's whatever is most helpful for you. This is definitely for you. So just stop me and ask away. I will be going through just the basics of genetics and genetics of cTTP just to get us started. And then before I dive into a discussion on genetic testing and genetic counseling for cTTP, I'll also go over some resources as well as some frequently asked questions. And then, of course, answer any questions that you guys have. Okay. So jumping into the basics of genetics. So I work in a pediatrics clinic. So a lot of times I ask, my sessions will start with kids asking, have you ever put together Legos or made a cake with mom and dad or watched mom and dad really struggle to build a shelf from IKEA? All of these things have something in common with our body, which is that they need instructions. You need instructions to put together Legos. You need instructions for how our body works too. So in all of our cells of our body, we have trillions and trillions of cells that work together to make sure our body is working properly. And inside our cells, we have our instruction manual packaged into chromosomes. So our chromosomes are what hold all of our DNA. And our DNA can actually be sectioned out into different instructions called genes. Another way I like to think about this is if you look, we have the alphabet, and you can put together different letters from the alphabet to make different words. The same is true of your DNA. So you can take different DNA molecules, your A, T, C, and G, you might remember from high school biology, and put together your different genes. And these are really the instruction manual for how your body works. So things like your eye color, your hair color, all of these things are determined by your DNA or your instruction manual. We can have different types of variants or mutations in our DNA, and we all probably, everyone in this room has different mutations in their DNA. And most of the time, these don't cause any problems. They're just unique to you. So we can have different substitutions where letters are put in a different place, deletions where letters are taken out, or insertions where a single letter is put in, or an inversion where actually the sequence or the sentence is flipped around. One way I like to think about this is, my name is Hannah. It's a palindrome. So if you flip my name backwards, it's still Hannah. So that's not causing it's not causing my name to change at all. If you take an H off at the end, it's still Hannah. But if you were to start to add letters in, you wouldn't necessarily be able to say it's Hannah anymore. So some of these changes are harmless, and some of them will actually cause certain health concerns. And that brings us to the genetics of cTTP, which I'm sure everyone in this room is aware, but I'll just to review, so cTTP is associated with the ADAMTS13 gene. It's located on chromosome 9. So you have 2 copies of chromosome 9. You get 1 from each parent. And you actually have 46 chromosomes total. This is a very important gene that gives instructions for making an enzyme that is involved in regulating blood clotting, which I'll talk about a little bit later. But I think it's really important to realize that everyone has 2 copies, and it's 1 from each parent. So to think about this in a little bit more detail, for someone to have cTTP, both of their parents are usually carriers of cTTP. So carriers don't have any major health concerns, but they have a chance to have a child with cTTP. So in this picture, we have the 2 parents up top, and they each have 1 working copy of the ADAMTS13 gene, or the blue copy, and they have 1 non-working copy, the orange copy. And so when both parents are carriers, there's a 25% chance to have a child who has both blue or working copies and does not have cTTP. There's a 50% chance to have a child who's a carrier, so having 1 working copy and 1 non-working copy, like mom and dad. And then there's a 25% chance to have cTTP. And this can be because the parents actually, so both parents pass on their non-working copy to the child. And the genetic change that the family can have off to the right here is, you can see the family will have either, the parents will either have the same genetic change, or they may have different genetic changes in different spots in the ADAMTS13 gene, but both of those mutations are causing the gene to not work properly. And this is kind of a busy slide, but what I want to focus on is what happens when we don't have ADAMTS13. So when we have 2 mutations that cause cTTP, we have this larger clotting factor that is collecting platelets, which causes those microthrombi and actually causes differences in the blood cell when we look at them under a microscope. When we have ADAMTS13, this actually cuts up that clotting factor into smaller pieces so that it's able to move through the blood vessel. I think one of the really cool things with genetics and cTTP is that we're starting to realize that there is some limited evidence for us to say, if this patient has these genetic changes, when will they present with cTTP? Are we able to say that this person will present in childhood or at birth? Is this someone who will present in adulthood or during pregnancy? And using that information to kind of predict when a person might need more support. This is definitely not a perfect science at this point. What I hope for us is that this is an area of potential innovation and starting to understand this genotype, phenotype, or what the genetic change, what symptoms it'll cause in a patient. So I'm going to go ahead and dive into how genetic testing works and kind of walk through the details of all of that. So we can get different sample types for genetic testing. Most often, you will be offered probably like a blood draw or a buccal swab, which is just a cheek swab. And I work with teenagers, so I'm going to clarify a mouth cheek swab. We can actually also test a pregnancy to see if the pregnancy is affected by cTTP as well. So we all know that during a pregnancy, the baby is surrounded by fluid, and we can actually take a sample of fluid, and there is some of the baby's DNA in that fluid. And that can be helpful for... Sorry. Yes, it's helpful to have you'd have to ask to check for this, and then it would be something where it's helpful to have a report of a family member so they can look for specific changes in the family. Okay. Regardless of what sample is collected, the way that genetic testing works is the lab receives the sample, they are able to take DNA out of the sample, and then they are able to actually read through the ADAMTS13 gene letter by letter and look for any extra letters, any missing letters, any of those different types of variants or mutations that we talked about earlier. So they kind of receive kind of a messier copy, the raw data, and then they're able to analyze this. And then this is what's actually put into your genetic testing report. This is a very time-intensive process, and many times patients are waiting usually about anywhere from 2 to 6 weeks for their sample to go through this process and for us to actually get a report. So this is because, it takes a lot of, I think, manpower and time to do this, and then also to write up the report and make sure that you have all the information. Absolutely.
So I got diagnosed with cTTP after my pregnancy last December. Would you suggest if I get pregnant again to definitely get this done?
I think it could be helpful. Yeah, I will never say you absolutely have to get genetic testing, but we'll talk about a couple reasons why it might be helpful for you too. Yeah, absolutely. Something to think about with genetic testing is not all testing is created equal. So ADAMTS13 genetic testing from one lab might differ to the next lab. And so this is important for your healthcare provider to know. And it's a fair question to ask in a doctor's appointment, right? Is what was the methodology, or how did they do my genetic testing? And is there anything we could potentially be missing? So this is especially true in a case where we have a patient where we know they have cTTP and we're only finding one genetic change. We might need to do a different type of analysis. We may need to look a little bit more closely at that gene. Absolutely.
Okay, with that being said, the Mayo Clinic and Cincinnati, the lab, they do the testing to look for other mutation variants. So basically, if you send it to like the other labs, they only test for the common mutations. So, in retrospect, most physicians should use these two labs, the Mayo and Cincinnati, because if they have a mutation like Harrison that was undocumented, what if it is a common? So, because there's a lot of mutations that are documented, as we know. So, what would your recommendation be on, which clinic would be look for all mutations instead of just a common?
So it's hard to recommend a specific lab just because there's I think utility for all the different types of methodologies. But I think in particular, especially when we're thinking about new genetic changes, it's really helpful to just work with a lab that'll offer help with testing other family members to figure out, is it helpful to test other family members, figure out if this is a new genetic change in our patient, or were we seeing more affected family members and we actually want to see, do they also have those genetic changes? And then also working with labs that just have a large database of patients who've had TTP can be helpful too.
So if they say genetic lab that only tests for common, potentially they would have a false negative report, right?
That is possible, and that would be a case where we would want to do a little bit more.
And so the two labs, the United States, should cTTP be referred more to those? Because it's so new. I mean, it's still baby steps. There's probably a lot more mutations out there than we know of, that we don't know of.
Absolutely.
And so wouldn't it be wise to send them to those two labs? Let
me just step in.
Sure, absolutely.
So if a lab has got the recommended authorities from genetics, it doesn't matter if they find a new mutation that hasn't been recognized. The point is, it's in the ADAMTS13 gene. So we're finding new mutations all the time. So they won't just look for common ones, because there are no common ones.
Right.
Okay, so they're going to do the whole adult 13 gene, and if there's a mutation that's never been detected, that we put on a big genomic database in the world and identify it. It doesn't mean that it's not relevant. It's the type of mutation and the frequency will dictate whether it's what we call pathogenic, or if it's just something, it's a variant, it's called a SNP, so it's something that's common that doesn't affect the adult 13. Does that help clear that up?
Absolutely. Yeah. Thank you so much.
What I was asking, so you could send the labs to like any genetic, is that what you're saying?
Well, I don't know the US setup.
Yeah.
Yeah,
okay.
I know what happens
Yeah.
in the UK, but it's
Well,
very,
just did it to you.
the genomics lab is a genomics lab.
Right,
So they run the same methodology that Hannah has told you, but then we look at different genes depending on the condition.
right.
If they've got relevant authorization, which the clinicians will determine, they will find what they need to find. And sometimes it can be difficult. Sometimes you do have to go back and speak to them. But there's no right or wrong. You will know right, where your preferred are. And it will be state to state.
Right.
Difference.
My concern is that we're missing some diagnosis. That,
That's what it's a conversation.
Yeah.
That's not about the genomics, that's about the diagnosis.
Yeah.
Well, no, I'm talking about like if we send it to a lab that for some reason doesn't pick up not an unknown mutation. Like what I'm saying is because you said that they have to have reason to look elsewhere, right? Authorization.
I think
So
if we're going, yeah, you're fine.
Anyway,
I mean,
okay, I get it.
I think if we're going based on like the patient's presentation, genetic testing could potentially miss a variant.
Yeah.
But we shouldn't rely on just genetic testing. We need to look at the patient and say they have very clear symptoms of cTTP. Our genetic testing is not perfect. It's not going to be perfect for a while. We probably are missing certain types of genetic changes. But we still, at the end of the day, we have to look at the person in front of us and say, this is what you have. And we may just not be able to molecularly or with genetic testing figure that out. Which,
As a carrier, my adults is very low, it's 34.
mhm.
So I did present symptoms at different periods of my life. Have you had that happen to other carriers? Have you seen that?
I have not, but I am newer to the field, so I might let some people who've been doing this longer than I have answer.
I would say not common.
Yeah, not
But
commonly.
It is concerned that potentially, carriers having lower levels of evidence of this could cause problems at some point.
Okay.
But it's not currently recognized as a specific disease. So, but your concerns are valid. I think we do worry
Definitely.
that parents and siblings, other family members who have lower levels of evidence could be at risk for some complications under the right circumstances. We're trying to understand that.
Right. Thank you.
Yeah, I think that's definitely an area of interest for us to understand a little bit more for carriers too. Any other questions before we move on? Yeah, absolutely.
So like, for our people, we have one variant that's really pathogenic, one that's likely pathogenic.
Yes.
Does that mean that it hasn't been documented, but based on what you presented, you probably have a genetic what is that?
So variants are scored based on certain criteria. So when we see a genetic change, we start kind of adding up points. Is this the first time we're seeing this? Is this something that's not? We kind of have these databases of healthier individuals that have had their sequencing done. Is it in this database or not? If it's not in the database, that might point us in the direction of, okay, we need to think about this. We need to look at this variant a little bit more closely. And so there's certain evidence that'll push you from likely pathogenic to pathogenic, but we treat likely pathogenic and pathogenic the same.
How can you help physicians order this test? I guess that's what it comes down to. Because there's been many times where someone will say, my PCP will order it, they just don't know what to do. They don't
Yeah.
know what to do. I mean, how does a normal doctor reach out and find a genomic lab that they can send these to?
We need more genetic counselors. Shameless plug for genetic counseling. But I think there, the clinics that are ordering this very commonly, I talk to people who are out in the middle of Texas, who maybe don't have as many resources with genetic counseling or a geneticist. And so reaching out to the people who do know, reaching out to things like USTMA will definitely help plug people in to those resources. Because I agree, there's, you have some providers who really know how to order this and others who have not ordered as often.
When you all look at the child, so I have congenital cTTP. I have a son. He has not been tested.
Okay.
He's never recommended to me. But he's getting ready to start a family.
Yeah.
And should his wife and he be tested? Because I know, obviously, in my case, it was obviously they both had that non-working
Yes.
mutation.
Mhm.
So should it be recommended to him to have his future hopefully mother soon be tested too?
Yeah, that's definitely something that we would talk about with him, would be that for him and his partner to go both be tested to see. It would be, more rare for her to be a carrier, but it's not impossible, and it does, it happens. So
I live in a really, really small town.
yeah.
In fact, I mean, like a really small town, very small town. And she's my mother and my father, both having that recessive gene are, it's
Exactly.
kind of like having an apocalypse right now. Like that, small.
Yeah. So I definitely think that would be something that would be helpful. And I'd be happy to share some clinical options at the end. Yeah. Okay. So thinking about the different types of tests that are done, labs will look at the ADAMTS13 gene, and they will do what's called sequencing, or basically just reading through that sentence, those T's, C's, G's, and A's, and look for anything that differs from their reference. So they'll look for those extra or missing letters. What can also be helpful, though, is to zoom out from the gene level and look at the chromosome level. So look for larger deletions or duplications. So this would be missing information that would disrupt the ADAMTS13 gene, or extra information, too, can also throw off the way that gene works. And this is why I think it's important for us to think about the way that the test is run, because sometimes you'll have a test that is just sequencing, and that's a perfectly good test, but then you might have a patient who has a deletion, so you need to add on that extra piece of testing. I would like to talk about some of the types of results that we can get from genetic testing. So we can get a positive, a negative, or a variant of uncertain significance, and I'll kind of walk through what each of these means. So with a positive result, we're either identifying one or two ADAMTS13 variants. So this either confirms carrier status, so one variant, or if you have two variants, it would be a diagnosis of cTTP. This can be really important in cases where presentation is less clear. So I've had cases where it's been less clear if it's cTTP or acquired TTP, and genetic testing has been really helpful here. But as I mentioned, genetic testing does not take away a diagnosis if you have symptoms of cTTP. This can also be helpful for your family members. So like we were talking about, seeing a prenatal genetic counselor and talking about testing for a future pregnancy. This can be helpful for their own healthcare and their own family planning as well. But genetic testing is not perfect at this point. You can also get a negative result. So this means that it's unlikely to be a carrier or to have cTTP. This is especially helpful for family members who they're doing the testing. They don't have symptoms, but they want to know if they're a carrier or have the condition. It's more reassuring if we know the variants in the family, so that we can say specifically, yes, we tested for those, and it's a yes or a no. We're seeing those variants. But we also are able, like I said, to sequence the whole gene or look for different changes. So we don't necessarily have to know the variants in the family. We can also get an uncertain result, which is kind of what I was alluding to earlier with that point system, is a lot of variants may start out in this VUS category, but then once we start to add points or take away points, they may be pushed into this likely to cause disease, or we know that this will cause cTTP, or it'll move to likely to not cause a problem or benign altogether. I think VUSs can be a frustrating place to be as a patient, and also sometimes with your provider, is trying to understand what this genetic change means. So this is something that your provider will look into and try to provide as much information as they can. But sometimes we have to wait a couple years for the science to catch up before we can say for sure whether or not a genetic change would actually cause a problem with the gene. Absolutely, go ahead.
Something specific to this. So, in the U.S., the way gene testing works is that almost all insurers will require a visit with a genetic counselor prior to any gene testing. So your primary care doctor can't just order a gene test in general. There are some exceptions, but the reason that this barrier has been put in place is because of this exact reason. Is that there are some diseases that don't manifest any symptoms, say like a cancer gene risk. So the person being tested has some symptoms of the disease. They want to know what's the risk I could get breast cancer, for example. And so, if you do this gene test and get a variant of unknown significance, then that creates a lot of stress on the patient. The primary doctor doesn't really know how to interpret the test. And we don't really know the significance of the patient.
Right.
Now, for this particular disease, it's a little bit different because we're not going to do gene testing unless we know that cTTP. So, if a variant of unknown significance or uncertain significance comes up, we essentially know that it's pathogenic. It just hasn't been described before.
Yeah, that's.
So this is a little bit different than other types of gene testing because we don't do the gene testing unless we know, as we say biochemically, what we see in the blood, this blood protein that the person essentially has. There can be times when it can be confusing when we're trying to figure out if this is acquired or not. But most of the time, even a variant of uncertain significance is a pathogenic mutation.
Yeah, that's.
Again, seeing a genetic counselor to understand these things is really important. So that's why that barrier is there. There are sometimes insurance gets things right. This is probably one of them, where I think it's important that if you're going to have gene testing done, you want someone who can interpret those results for you. You don't want a primary care doctor or even really interpreting these results. You want someone who has familiarity. So that's where that comes from. That's why there are barriers to gene testing. It's more complicated than sort of a blood test.
Yeah.
Question. Can the atoms change throughout someone's life in a family that has cTTP, like if it presents at pregnancy or at adolescence? Can they maybe show as not having it earlier in life and then later on show that they have it?
So, yes, I think that, I think we can see different presentations in the same family, but your genetic information won't change throughout your life. So that's what your DNA is, what you're born with, and it stays the same throughout your life. But we do see, I think, different presentations among even family members.
I'm gonna go on that. So
Sure.
I didn't get her genes tested, but I got my daughter's Adams 13 tested. Her levels are perfectly normal.
Yeah.
Beautiful, made me so happy. Could there be something, like obviously her gene isn't tested, so if she has that mutation, is there something later on in life that could trigger her, even though her Adams 13 is like, we might not even know that, but we might not even know that, so the answer might be, I don't know. Could there be something later on if she gets pregnant or sick or something that would trigger a TTP episode if right now she doesn't seem to have it at all, or probably not?
As far as, I might let some of our, I don't think so. I think if her Adams TS13 level is normal, I think that's
She
fine.
does, so she should be okay. Okay.
Yeah, I think that should,
Real quick, so I've had genetic testing for a cancer diagnosis. He's never had genetic testing. We do have a son together. Would just an Adams TS13 test on him be sufficient for a 14-year-old, or should we do the whole genetic testing on him?
I think genetic testing, we know that he carries probably one of the genetic changes that you have. So it's not something I think we have to rush to do at 14, but if thinking for his own family planning in the future, that's information he might want to know, which genetic change he has, and then also to talk with his partner about getting tested.
If they did mine, of course, we weren't looking for anything like that. Would they find that mutation that leads to that? Like, could I go back through my same paperwork? Or do they have to specifically be looking for that?
They have to specifically order the Adam TS13 gene. So for a cancer indication, they probably wouldn't have ordered that. Yeah. Any other? Yeah.
So, I've had this my whole life, obviously, but I've been in remission 2 different times where I've been tested, my Adams TS, so I have 0, I have none.
Right.
And during my first remission, I wasn't tested because didn't even have a name at that point.
Mm-hmm.
But, and it was 13 years that I was in remission.
Okay.
Then I got pregnant, and then I went into another remission for 15 years. And the second one, I was tested, and there was Adams TS13 present. It wasn't astronomical amounts of it by any means, but it
Right.
wasn't like literally 0 or traced. So how, first of all, don't know why it went into remission, don't get it at all, but so that's why when she asked if you could change from time to time,
Mm-hmm.
I've never had it be, I'm consistently tested. It happened since I got pregnant back in 1990. So it's kind of confusing to me when you say that.
I think if we're testing Adam TS13 in someone who's not being treated for cTTP, and we're just testing to see if they have a low level, and they have a normal level, I think we wouldn't expect that level to drop. But someone who's being treated for cTTP might have differing levels of Adam TS13. You weren't treated at all.
I wasn't treated at all. I started prophylactic infusions because in 2015 there was a mass in my bladder,
Mm-hmm.
and that was Helber. It was
Okay.
huge, and it was all Helber.
I suspect that this could be a difference in the way that the TS13 level is being tested. So first of all, the test for TS13 only came around in 2006, so it hasn't been around all that long. It's very difficult to do. That's why there are only a few labs in the country that routinely do it. It's becoming more common because there's new technology that's being used to test. But different labs report their different levels of flow that they can reliably report. So a lot of labs will say this, scale of 100% is normal, maybe down to 70% at some labs is considered normal. And then anything below about 10% of normal, they just say less than 10%. They can't differentiate, say, between 0 and 10. So they just say below 10. And so, part of this is, if you send the blood test to different labs, at the very end of that very low level, you may see differences reported. There are other things too, the way the sample is shipped and other things that can create discrepancies between levels. Ideally, yes, biologically, if you have this disease, your Adam TS13 level should be exactly the same, no matter when in your life you tested. The reality is that the tools we have to measure that vary over time in between lab and lab. So you may see differences at different times in your life when you're doing this testing. If you say, well, at one point you're less than 10%, and then you test another time and you haven't had any treatment, or you're 80%. Okay, well then maybe the diagnosis is wrong. And that happens. I mean, these diagnoses can be difficult to make. If it's a difference of, I was told I was less than 10% one time, and then we sent it to a different lab and that reported 8%, it's probably the same. It's just different technology, different lab reporting their comfort level with their levels. So we can talk more specifically if that sounds more like your story. But it is hard. This is a difficult test to do. The technology changes over time. Different labs are. So it can create a lot of confusion.
But it's consistent, mine is consistent with sentence.
Okay. Well, even the same lab can change their technology. So,
That's true.
they update their testing platforms.
Was it changed that drastic? Is it changed that drastic?
Yeah.
Like normal?
So mine is like, my test is 0 to 3% or 5%, okay? And this was over 10%. It wasn't high, it was like 13. That's a difference. And I had absolutely no symptoms whatsoever. None.
Big difference.
I think it is a one-time 13%, and all the rest are consistent. It's probably that.
It was several tests that came back as 13.
Yeah, I had it done from the time, once genetic testing was available. I had a really good doctor back then, and she studied cTTP, so she found out about it and said, why don't you have this test for me, even though I was a physician, and she wanted it for her studies, and had me do it for like 3 or 4 years, like every other year.
So can I just help with some of this differentiation and following on from Marshall? For a diagnosis of TTP, you need an Adam 13 less than 10%, be it immune or congenital. A few years ago, we did an international collaboration. All of us got together to try and put terminology to help people understand what they should be aiming for. So less than 10% is clear. There is a caveat between 10 and 20%, which is specifically related to patients with congenital TTP. Because you can have slightly higher levels, and you can still have congenital TTP. That doesn't mean it doesn't fluctuate. So that variability up to 20% in the face of having a clinical scenario that looks like TTP, it can still be congenital or immune. So you need to do antibodies, and you need to repeat it and see the pattern.
Yeah.
The only other thing that I was, does that make sense?
Yeah, totally.
So it doesn't change your diagnosis.
Right.
And the remission thing is a whole other story. So the only way that you have remission in congenital TTP is a sustained normal platelet count, and that's normal, and high Adam 13. Don't ask me what high means, because we're still trying to work that out, and normal is normal. Does that make sense?
That totally makes sense.
Does that clear that up?
Yeah.
Everyone understand?
Thank you.
We try to do a bit of work in the background to help rationalise some of these phenomena that we do see in patients and congenital. Although it's a new word, speciality, it does have certain nuances that we need to consider.
Definitely. Yes.
So some of us older patients, we've seen our diagnosis change probably 5 or 10 times throughout our lives. So at one point it's, you have Hemorrhagic syndrome. Well, but that doesn't happen a second time, so you have something else, and then you have something else. We didn't know what we had until 2006. So there's a lot of stuff that we're still learning about all of that. I had no idea about any of this stuff. I thought it was just playing accounts. You know, it's like, okay,
No, you're fine.
Hemorrhagic syndrome. Nobody told on itself. What is it? We're learning all the time.
You had a question?
I just have one question about the remission. Because our son has cTTP, our doctor's not saying that. So are you saying like that's a 5%? I mean, like, they're not talking like that's a possibility, for instance, remission, that's never like a use. It's like he's gonna have this for the rest of his life, he's not treated for the rest of his life. That's it. So like, when what's surprising what you said, remission is cTTP. So are you saying like you have to have high platelets?
No, I think you're right. I don't think there is a definition of remission. What we have is optimal therapy, which is sustainable platelet count. You can have a normal platelet count and still have symptoms of be at risk. So it's a sustainable platelet count and prophylaxis. Remission, I'm not sure we've got a definition of that. If it's not, we haven't got that. In immunity, I don't think the kind of journey was. I think that might make the colleagues backing up on.
Stay stable.
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 Yeah.
I was never treated as a child, and I didn't during any time as a child. And I never, after I had my son, to 10 years, I went into a remission, and I was not treated for anything. There were no infusions, no anything. I just took an aspirin a day. That's all I had.
Siobhan had a splenectomy, and so his platelets remain over 400,000. So we can't use that as an indicator for his active cTTP anymore. We have to watch his creatinine levels, his GFR, and more of the kidney issue for him, or cognitive, of course. So the splenectomy changed the platelets. Does it change anything with the congenital cTTP, or is that platelets decline just an indicator?
I think you have it right. This one shouldn't change this only in the sense that it resets the platelet count. Because we think of the spleen as these two functions, it's part of the immune system. So people have their spleen now, they take vaccines every 5 years, and that's an easy thing to forget. So and then it's the recycling center for the blood cells. So when you take out the recycling center, the platelets move on. So it's just a reset. It's just
And then the problem is if he gets too high, even though he takes Plavix, if they get too high, then it's almost like he has he still has like microstroke, so it's almost like you have to like double up on his medicines to keep his platelets, like he can go too high or too low, but since his splenectomy, he just goes too high. So we have to keep an eye on that. So kind of an interesting.
So, this is more, this is tomorrow.
This is your.
All right. Okay. And I think it's time for us to.
We are technically at time, but if you have a few more slides you really wanted to get to or something, I think we'll be fine.
We can take a 5-minute break if people want to forego the break to continue the discussion. We
Okay.
can absolutely do that. Or if you really want the pastries we have set outside, you're welcome to leave and we'll continue the discussion.
Yes.
It is going to be recorded and available online as a video. So.
Okay. I will go through slides, but feel free to take bathroom breaks, go get pastries. So just to look at the specialties for genetic counseling, you can see prenatal, pediatrics, adult. Really, genetic counselors can be helpful across the lifespan. Thinking about what a typical appointment would look like. It's really helpful to bring records. So if it's not in the medical system or medical records, bring family member records, personal records, genetic testing records. Please bring genetic testing records if you have them. You may meet with a hematologist or a geneticist the same day as the appointment, so it may not just be with the genetic counselor. You should plan for a longer visit. And then genetic testing may or may not be able to be done the day of the appointment. It really depends on the clinic setup and insurance authorizations and things like that. So it may just be an initial meeting before you do genetic testing later. Your genetic counselor will walk through your family history with you. So we'll take a very detailed family history, draw everything out for you. And then we'll also go over any genetic testing reports. So if you've already had genetic testing and you'd like to walk through your report, they'll walk you through your result and kind of the summary of the interpretation of why they called a variant pathogenic or benign or VUS. And then something that genetic counselors can also provide to you is on the left there, we have a family letter. So this is to help inform other family members that they may wish to be tested for cTTP and may wish to have genetic testing, as well as a summary letter of the condition and what testing was done. And that can be really helpful just to have in your records as well. Something that I'd like to touch on just briefly is prenatal genetic counseling can be really helpful. ADAM-TS13 may not be on all carrier screening panels. So you may have done carrier screening prior to your pregnancy and ADAM-TS13 wasn't on there. And so you may wish to do additional testing later. We're also all likely carriers for some genetic condition outside of TTP as well. So it can be helpful to see if you and your partner match up for anything else. Some people will choose to do what's called pre-implantation genetic testing, which is where a couple goes through a cycle of in vitro fertilization or IVF. And then we're able to actually test the embryo before it's implanted. So we are able to take a couple cells, do the genetic testing, and determine if an embryo has cTTP or not. This is something that can be really expensive, but there are insurance companies that are coming around or different companies that are